Welcome to the Kratom Sobriety Podcast. My name is Charlie, and this is a special episode. We have a guest expert, an academic from Wisconsin with a toxicology background, and he was a co-author of a recent study that he will explain in a little bit. Welcome to the podcast, Dr. Feldman.
Thanks for having me on. It's fun hearing you have to do the introduction a few times because I have to do that often myself.
We don't have to do one continuous solid take, but we do have edit functions, especially to edit out all my mumbling and stutter words and stuff.
I've been there. I understand. But yeah, thanks for being here. I appreciate it.
Could you introduce yourself, your academic background and things like that?
So my name's Ryan Feldman. I guess I'm an academic. I actually describe myself as a clinician, meaning most of my job is dealing with patients and their problems. But I do have an academic background. So I'm an emergency medicine pharmacist at a hospital. So I see patients who are acutely ill from all sorts of things, including overdose, as well as drug toxicity, and help make sure they're getting the most appropriate medications. I'm also a clinical toxicologist for a poison center. So I get calls from hospitals around the entire state asking, hey, how do I treat this poisoning, or what is this poisoning to, including Kratom? Or how do I treat withdrawal from substances like Kratom? We tend to get calls about things that providers are less familiar with. And Kratom was one of them a long time ago. Now I think more people know about it. And then my other job is as an associate professor. So I guess technically I am an academic. It's actually the smallest part of my job, but I do teach at a medical school and a school of pharmacy and do some research, although I do that in all aspects of my job. So that's who I am.
This might feel a little out of place, so we like to humanize our guests. Do you have any travel plans coming up this summer or beyond?
I wish I had more, but I have 2 young children, and it's pretty hard to take them on long flights. I'd love if I had more travel plans. I think we're going to go to Florida for some weddings, but we're going in the summer, so it's going to be just hot.
Okay. Hopefully it won't be too humid. Do you have any live music in your future?
Oh, where I live, we have the world's largest music festival. So this summer I'll be going to that. I haven't even looked at the bands yet, but I'm excited to see some people. I've certainly I think I'm going to go see AJR at our state fair, which will be pretty fun. But yeah, I'm a big live music fan. AJR, Noah Khan, I recently got to see. I'd love to see him again. Those were awesome.
I just learned about that largest music festival because there was this movie about this Neil Diamond cover band with Hugh Jackman portraying, and Kate Hudson was the other star in it. But I think it was 30 years ago, they performed with Pearl Jam and at that state fair and that big music festival.
Yep. It's Summerfest. It's called. It's great. It's really cool that we have it in our city. I love it.
So as your job in emergency medicine, have a patient presented to you with a Kratom overdose?
I have seen, Kratom overdoses before. It's not the largest problem by a long shot, but I have seen it. And it's been an interesting, I think the first time I saw it, I was actually a little bit astounded. I was somebody who had received naloxone from a police officer related to Kratom. And I said, there's no way that they took enough Kratom that they needed naloxone. But did happen. And I said, okay, we'll take a little bit. If we've run into, actually, really what I see more is withdrawal in people withdrawing from the substance, or even having precipitated withdrawal from Kratom when they're being initiated on other substance use disorder medications. And that's honestly what I deal with the most in terms of Kratom.
There is a couple of case studies in the literature of Narcan being used, and then they tested for some other opiates and there wasn't any. Since a lot of Kratom intoxications and overdoses are often multi-drug, it's better safe than sorry to see if the naloxone will work to save somebody.
And I'll clarify here. It wasn't a question as to whether naloxone would work for me. It was just, I was surprised to hear someone had taken Kratom in enough of a dose that they had become sedated. But I do 100% think that can happen. And there are case reports of deaths and other things out there from Kratom. There's no drug that's completely safe. It just wasn't something at the time, this was about a decade ago, that I was hearing much about. And I primarily heard of Kratom as a substance that people used over the counter. There weren't death reports out there at the time. So I was just surprised. And in that specific scenario, I'm also not saying kratom was the cause. There are often polysubstance reasons for people to be sedated and then get naloxone and improve. But as I said, I've seen people acutely intoxicated with kratom, and I've seen people dealing with the after effects of not having kratom in their body from using it regularly. That's my experience with it.
Could you tell us a little bit about your podcast about poison?
So I have a podcast called The Poison Lab. So my job in toxicology or with the Poison Center is a little bit unique. It's very interesting, and I love my second favorite thing to do in the world is help people who have been poisoned. My first favorite thing to do is talk about poisoning because it's all the fun parts of it without anyone's life or limb on the line. It gives me a little bit more time to do the slow thinking that goes into how we manage overdoses or why we manage them the way that we do. And this is a podcast where I bring on other experts in poisoning and drug overdose, and we talk about the different aspects of management or play some games where we give each other cases to see if we can figure out what the poison is to help us develop our differentials so we can better identify patients who have been poisoned. It's an avenue for me to explore that without having to worry about somebody having negative health effects, which is also always the problem when I'm dealing with real people. And it's a little bit more fun this way. So if you're interested in hearing about what people who work at poison centers deal with or how we think about treating poisonings, you can check it out. It's thepoisonlab.com.
Thanks. And now that I understand that you're more than just an academic, I understand maybe why you started researching kratom. Down here in our part of the Midwest, we say kratom.
I do not pronounce it correctly. I'm not saying that my way is the right way. I've heard researchers and people say kratom, tragenine. I am not making any statement that I know the right way to say it.
Or kratom or ketchum, all sorts of things. So, but why did you decide to look at kratom a little bit more closer in a research mode?
So I live in Wisconsin where it's a banned state. I really didn't know much about kratom 10 years ago. We would get calls about it. And my first time I ever encountered it was somebody asking how to manage the withdrawal from it. And I was saying, this is an interesting substance. I got to look more into this. And then as the years have gone by, our state actually wanted to introduce legislation to not ban it, or right now it's Schedule 1 in our state. And they wanted to introduce legislation around a Kratom Consumer Protection Act, where they basically would say kratom is legal for sale. You would regulate it down to a percentage of the mitragynine that's in there, the 7-hydroxymitragynine that's in there, and then everybody was allowed to purchase it. So when that legislation was introduced, they brought it over to one of our medical societies, which is the Wisconsin American College of Emergency Physicians, to say, hey, do you think we should do this? And they said, I don't know what this is. So they sent it over to us at the Poison Center in our medical toxicology group at the Medical College of Wisconsin to see if we had any insights on what the health impacts could be from this. And we actually got into a debate amongst ourselves over whether it would be a good thing or a bad thing to increase availability but regulate the product. And we just realized there's absolutely nothing out there evaluating the impact of these regulations. We have toxicologists from Denver where it's widely available, that people train at different sites and they see this all the time. And we have people who trained at banned states and they're like, we really never see much from this. So we had a philosophical discussion about what is the overall good of regulation. We realized there's no data out there. So we wanted to take a look and just see what the data shows. And the metric that we use, the one that we are most familiar with, is poison center calls, where anytime you call a poison center, there is a trained healthcare professional on the other end of the line, and they're going to document what the substance was, as well as any medical outcomes that occurred. Did the patient have a seizure? Did the patient die? Was the patient totally fine? So this is all logged in an electronic health record that then gets used to aggregate data and help us look for trends in poisoning. We decided to take a look at poison center calls and the health outcomes associated with them in states with different regulation and compare them to try to get an idea of, is regulation even doing anything, at least from the perspective we deal with, which are poison center calls.
Could you introduce the name of your paper? We'll put a link in the show notes for it, and maybe just some of your top headline findings from the paper.
I got to look it up because it is a mouthful. Yeah, the name of the paper is Association Between State-Level Kratom Regulations and Poison Center Reported Severe Medical Outcomes and Healthcare Use a United States national analysis. So what that's saying is we chopped up the entire US and we look at rates of poison center calls that Kratom was involved in. And we looked at rates per 100,000 in the population. So for example, in Wisconsin, there's about 4 million people. So we looked at the amount of calls per 4 million people to try to standardize it. Because obviously you're going to get way more calls about Kratom in California, which has 80 million people. So we standardize it per population. And we looked at the amount of times you got called at a poison center about somebody who had ingested Kratom and potentially other substances and wound up in a hospital, in an emergency department, or had a serious medical outcome like death, refractory seizures, not even one seizure, but multiple seizures. We didn't count. A seizure is a very big deal, but if you had just one seizure, we didn't count. You had to have multiple seizures. These are what we call major medical outcomes, which are coded by the National Poison Data System as anything that is life-threatening or potentially disabling. So these are things like cardiac arrhythmias, multiple seizures, needing intubation. These are examples of the kinds of health outcomes, severe medical outcomes that we're looking for. Now, we chopped up each state by each year, and we basically said, okay, in 2020, all the states with bans versus all the states without bans, or all the states with Kratom Consumer Protection Acts, which are things like age restrictions or quality control restrictions. We said, okay, in 2020, what was the difference in these healthcare visits or serious outcomes between these regulations? In 2021, what was the difference? And we made sure every year that if Wisconsin changed its regulation in 2021, it would be lumped into a different category. So we're just comparing the rates of these outcomes over time, depending on whatever regulatory status the state was in. And what we found is that the rate, or what we measured was called the incident rate ratio, of serious medical outcomes or severe medical outcomes and death reported to poison centers was much higher in every single regulatory framework except for a ban. There was no difference between having a Kratom Consumer Protection Act or being totally unregulated. It made no difference in terms of the amount of times that I get called about somebody who has died and had Kratom associated with that ingestion, or who has had a serious outcome, as well as overall exposures. The amount of times you get called at a poison center is way down if you're in a banned state compared to a non-banned state, or even a Kratom Consumer Protection Act. The only thing that actually seemed to make any difference was just making it a scheduled drug, unfortunately. And I'm not saying that this is just to be clear right out front, this is one perspective of data. There are many views you need to look at, other harms that are not measured in this data. But this is what our data showed. If you want to reduce the times your poison center gets called about Kratom, then a ban is the thing that would do it. But it doesn't look at how many times people are dying from other opioids. It doesn't look at what kind of other risky behaviors happen when Kratom disappears from the market. And it doesn't even really claim that poison centers are capturing all Kratom data. That's a big limitation, I would say, because poison centers are passive reporting. We only find out about things when somebody decides to call a poison center. Now, most people who are experiencing Kratom toxicity in healthcare are getting called into a poison center, though. I do think that's true because our data tends to skew. We do not get called by every hospital provider about a given opioid overdose because they know how to manage those. We get called about weird stuff, and Kratom to most healthcare providers is weird stuff. We get called about a lot of it, I would say.
And obviously, a happy Kratom consumer isn't going to be calling the poison control center to tell them about their great experience with it either. There's a low-hanging fruit here that, being from Wisconsin, it's known to be an alcohol state. Do you think that you have some kind of bias against Kratom because of the influence of big beer?
I have really no bias one way or another, but I totally think it's a great corollary to just the discussion around prohibition in general. Kratom is not the biggest problem in the US. Harms I see from legally available substances like alcohol and now in Wisconsin, Delta-8 and analogs of THC are through the roof compared to how often I see something from Kratom. And if you look at nationally, that is the case, right? Yet those are legally available substances. Now, I personally would prefer the amount of kids I see in hospitals constantly from eating 2,000 milligram Delta-8 THC edibles. I would prefer there was a lot more regulation around that specifically, but a different story. I have no idea who lobbies for what in terms of Wisconsin, but we have a very large tavern league, and I think they do spend a lot of time ensuring that alcohol is protected. I'm not a valid source for any of this, but I think that there is a lobby for alcohol here, and they might be interested in making sure that's still a preferred product, but I don't know.
Please forgive me for making a side comment that was a little bit off what we're discussing here. But so one of the interesting things that your data stopped at 2023, which is before the explosion of 7-OH for the most part, because about a couple of weeks before your paper was published, the CDC actually did their own look at poison control data about Kratom from 2015 to 2000. And there was this big jump of poison control calls, and most people are writing it off as it's 7-OH related, and there's probably some truth to that. But actually, your data set is before the onset of those synthetic and derivative products of 7-OH. Was that on purpose, or was that just a happenstance? And what does that say? Do you think your analysis does exclude 7-OH?
I don't think our analysis excludes it, but we don't delineate which effects are from what. So it's not precise enough to get in there. It was not on purpose. We started this project in 2023, and that's when we pulled the data up to, and it takes a long time to publish your studies. I'm happy to see other data coming out. I know the CDC MMWR report that you just discussed. I know some of the authors on that. They did a great job delineating really the rapid rise in Kratom that we are seeing. There's a lot of discussion over 7-OH or other more potent analogs, pseudoindoxyl, that kind of thing. Not analogs, but maybe metabolites, and the impact they're having. Really, we see this with every drug in the world. It's like the human evolutionary programming is to concentrate and make more potent any value substance you can find. So you see we have something that stimulates the dopamine reward network. I don't know, codeine that we find in poppy plants, let's turn it into heroin. Nope, now let's make it fentanyl. Now let's make it super, right? It's the same thing. THC, I now have THCP, which is basically 30 to 50 times more potent than THC is. This is a trend we see with almost every drug, is that once it gets the hold in some population, there's just further and further concentration and refinement of analogs until you get extremely potent substances. I think that's what we're seeing with 7-OH and pseudoindoxyl, and that's part of the dependence train that happens too, is you need higher and stronger doses of these drugs in order to maintain the same effect. So that's part of why some of that comes about as well. And it's also easier to distribute potent substances because you need less of it to get the same effect. So you get more money for those kinds of things. But sorry, a side tangent on why I think some of these things are coming about. But the 7-OH has been around longer than 2023. The concentration, I'm sure some of it's captured in our data, but it is something that should absolutely be looked at, is like, what is the impact of just those concentrated products versus really a leaf product or other kind of an extract, I think is a very important delineation.
Some people argue that the iron law of prohibition is that products get more and more potent under bans. I would argue a corollary is under capitalism, the same dynamic happens where products get more and more concentrated from exactly what you just described. But from your paper, it was from 2010 to 2023, and you found roughly a 60-fold increase of poison control Kratom exposures. So what does that say to you?
There's a few things to think about. Number one, poison control. Sometimes we don't even have the ability to document some of the substances we're hearing about until later into an outbreak. So some of it might be just better way. For example, we were not coding 7-hydroxymitragynine for a long time, but that's a specific code. We were just calling everything Kratom. So some of it has to do with coding and getting better at coding and actually monitoring these substances. But really what this tells me is largely poison center calls correlate with national trends, and more people are learning about what kratom is and using it, is my assumption of that association. I doubt we were just missing the boat for 10 years and then suddenly we figured out, oh, everyone's using kratom. So it's interesting though, in the banned states, we did not see such a dramatic rise in exposures. It's very difficult to measure how many people are using kratom. You could look at surveys they do in the Protecting the Future survey, I think they call it, but they survey drug use rates that are self-reported from high school students. That might be a better way to actually assess something like this. I wouldn't posture that Poison Center data is an estimate of incidence, data of use overall. It's, as you said, nobody calls us when they're having a good time.
And the prevalence of kratom use is highly contested in the literature, and the industry has estimates that are way higher than more random surveys like that one that you're just talking. It ranges from 2 million people to 24 million.
In a sense, it's almost who cares. People are using kratom, and that's important enough. So it's enough to cause of one person, or if 350 million people are using kratom, I guess it's a different story about how big the problem could be, but a lot of people are using it. I think a lot more people are using it as of recent, probably due to proliferation of social media advertising would be one of my guesses, because in this time window, 2010 to 2023, social media became a lot more of a problem, I think, for all things. But I think that could be part of it too. Just information sharing has changed over that time too.
In your paper, you had 4 graphs about different outcomes, which was the first time I'd seen that level of breakdown. So one of the categories was, let's see, severe medical outcome. How frequent was that?
So severe medical outcomes, as we talked about, is either death from a kratom-associated death, or somebody having a very serious medical event happen that could threaten their life or cause permanent disability. So as I said, multiple seizures, not just one. These are actually defined in America's Poison Center's coding definitions. So when you call, the healthcare worker on the other end will say, oh, this happened to you. I have to code this as a major medical effect. Oh, you had multiple seizures. That's a major effect. Oh, you had a life-threatening heart arrhythmia. That is a major effect. Oh, you were intubated, meaning they had to put an airway tube in you because you stopped breathing. Major effect. So we saw severe outcomes rising throughout the entire nation at a lesser degree in the banned states. It was not a small amount in terms of the penetrance of severe outcomes. Actually, more so the healthcare utilization is what was pretty concerning. I think we had 1 in 7 hospitalization, 1 in 7 calls were hospitalized or potentially, I don't have the data right in front of me. 1 in 7 maybe were hospitalized, or 1 in 7 maybe wound up in critical care. I can't actually.
It was 1 in 7 was hospitalization.
Yeah, so hospitalization, and now let's give the right context here. The kratom user might have also they could have been hospitalized for alcohol withdrawal. There's a lot of things that could have played in here. This is an association. We're not making causation statements here. But the fact that we see some of them are kratom, right? There was a lot of single substance exposures in here too, which was just kratom. And kratom would play a role potentially in any of these other polysubstance exposures that we are looking at as well. But yeah, they went up. Healthcare utilization was a big thing that a lot of states would think about, because this is something that costs the state money if their healthcare utilization is going up in their state insured population. We didn't look at, so that's something that a regulator might think about. We didn't look at insurance status. That's not something that we can look at. That'd be something to think about too. If regulators really want to figure out what's going to cost them or what net good in society this is doing for them.
One of the most controversial things about kratom is it's still widely believed that you cannot die from kratom. And I know you're a toxicologist, and there was reports of deaths to the poison control centers. What is your thoughts about lethality?
So interestingly, first off, there's nothing you can't die from. That's just a false statement. Poison, the dose makes the poison. I actually did an analysis that's buried in what's called the America's Poison Center's annual report. Okay. It's back in, I think, 2023. We took a look up as a group at 3 unregulated substances. tianeptine, phenibut, and kratom. Have you heard of tianeptine or phenibut?
Yes.
Okay. So when I talk about the relative danger of any given substance, we use something called a morbidity index, which means out of all the cases of exposure, how many result in a very bad outcome, the ones that we measured, severe outcome or death. And kratom actually has a lower morbidity index than some of these other things like tianeptine or phenibut, meaning we saw a ton of cases. The reason we were seeing a larger amount of serious cases is not because it was more potent than these other things. It was more or less just that we're seeing a ton of cases, so the small amount of serious cases are rising. And that's going to happen anytime you bring something to a larger population. You'll just start to see more serious effects because more people are using it. So if there's a small percentage of people that experience that, you'll see that larger number. Now, if the question is, can kratom cause death? I think there's no drug that can't cause death. I can't tell you how much would cause death. I've read some case reports of kratom being the only thing that they're finding in people. And if you want to get into causation, there's a whole public health framework we could talk about called Bradford-Hill criteria. I don't think we're going to break it down here, but it is certainly has mechanisms that are realistic to cause death. And when I reviewed in our paper, we actually write out the case narratives of all the deaths that we found. They're similar. It's like a sudden collapse, or it's often a young male found at home in cardiac arrest. We don't always know the details around the death, but it's kratom is found in their blood. Sometimes they have to do with these more concentrated products. There are potentially cardiac effects that many opioids have cardiac effects. And sometimes you can induce proarrhythmic changes. A death from respiratory depression, we don't have enough details to know exactly in these deaths what the cause was. It could potentially be a mechanism. One case describes somebody having a seizure and then dying. So I absolutely think that kratom, like any other drug, can cause death. And I do think the more potent and more concentrated you make a substance, the more likely you are to experience that. So as we move down the trend of 7-hydroxy and pseudoindoxyl concentrations increasing, it wouldn't surprise me if we ran into more deaths.
There's a new paper looking at the Florida deaths. It's called the Orlando Case Control Study. I'll have to send it to you, where these researchers looked at the autopsies from 150 deaths and use some evidence-based tools to confirm the determinations. And there was like 9 deaths that were kratom alone and 38 that were kratom caused. And it had a lot of the things that you were just describing. I'll send you that paper.
Let me point something else out here too. The amount of kratom deaths, whatever they are, is wildly underreported. The ones that we know of we happen to have the right history. Kratom is not something that's usually looked for, and wasn't, at least, in most medical examiners when they do an autopsy and send that blood off for toxicology testing. Some labs don't even look for it. So it's very likely that it's getting missed if it is happening. I'm not saying that it's 1,000-fold underreported, but there are cases that are out there that I'm sure do not get captured, because the way that you would find out is by testing their blood to see what substances are in there. And it's just not something that always gets tested, especially if you don't have any history about them using it. And a lot of people don't report their kratom use. In fact, we've run into problems with that where you don't know they're on it because it's just something they're purchasing and they might not even know it's an opioid. And then sometimes they can get withdrawal precipitated if you give them an opioid antagonist, things like that.
The industry just insists that there's all this overcounting and that all the attributions to kratom causing the deaths are all mistakes. We've interviewed about 9 family members. They're a surviving member, and one of their family members died from kratom. We're not saying that kratom is as deadly as fentanyl. It is just an underappreciated dynamic that's happening in the country.
You know, what's funny is I have no bias here. I wanted to answer a question is, what is regulation doing? I'm not pro-ban. I'm not I'm largely, in general, I'm pro-regulation of a lot of these things versus unregulated, because I see a lot of harms from unregulated substances where big dose changes hurt people. But I'm just pro not hurting people. And whatever the best way to do that is the way I would want to go. And what's funny, when we published this paper, which we have no funding for, this is totally unfunded. We just wanted to answer a question. I got a lot of comments from people making statements like, this is going to hurt people. We tried to be very clear in our paper. We needed to explore other harms too. But I've yet to get a comment from someone who isn't selling kratom to people. So the industry bias here is very significant, that it does seem like there's some people who really want to make sure this is still available and sold and widely accessible. The thing that worries me about kratom is that it is not clearly labeled, that this can not only cause but you can buy mood boosters. It's marketed as a mood enhancement. If you were selling someone an opioid agonist as a mood, it's got to be known that what you're buying has opioid activity. And I've seen people unintentionally develop dependence, which is something that happens from any opioid. And that also scares me, that someone can buy something over the counter and develop dependence on it and develop a substance use disorder because they were not aware of when you buy a pack of cigarettes, it says this causes cancer. Alcohol, very damaging, but people know what they're getting into. I don't know that people know what they're getting into with the marketing that is allowed with this unregulated substance. And that actually worries me, because people, if you want to talk about harms, there are harms on both sides. But one of the harms we also need to consider is people unintentionally becoming dependent. That's a very big thing.
That's a major theme of our podcast. Many of our guests had no history of addiction, and there's a wellness washing with this product that really obscures the risks. And just today, I was listening to a hearing in South Carolina where a Kratom vendor was equating again Kratom to coffee and was really upset that the regulators in that room were comparing it more to hemp and Delta 8 and those kind of products, and saying, no, it's really like coffee. It might be habit forming. Do not think of it as an addictive substance, which the lived experience of everybody that's appeared on our podcast as a quitter, the idea that Kratom isn't addictive is nonsense, but it is really frustrating. This is a product that does blindside people because of the mismarketing and the lack of warnings on a lot of the products.
I like the term you use there, wellness washing. That does seem to be a big problem with this. I'm going to borrow that if you, it's just not being forthcoming about what it is. So people can't make the appropriate risk assessment when they're entering into a relationship with this substance. And you want to talk to dependence and addiction. They're very overlappy, but there's no doubt that kratom can cause dependence, which means your body becomes tolerant to the effects and you need to consume more of it over time in order to achieve the same level of effect. Addiction often comes into play once you are dependent on a substance and then you're starting making negative impacts to your life in order to continue to use that substance. But most things that are addictive are dependence causing, like kratom is.
We've heard with kratom, the life crushing kind of aspects. One is often money. So some of these products become really expensive, so people getting a lot of money problems. And then second, there's a lot of health issues. People start having seizures, they lose a lot of weight, but then they continue using kratom and have an inability to quit. So it leans more being towards the addictive side rather than a mere dependence. But putting your clinical hat on, and our audience are mostly people, either they've already quit or they're trying to quit. What have you learned about kratom withdrawal and ways for people to manage that?
I'll just say this, the jury's not out on the best and most appropriate way to manage kratom withdrawal, because it is more of a rare entity compared to the other things that we are really routinely managed, like alcohol or other opioids. Primarily, kratom withdrawal treated as opioid withdrawal. In fact, there's many case reports of using things like buprenorphine, which is a opioid, a substance we use to help people who are dependent on other opioids like fentanyl in order to maintain sobriety off kratom. There are other agents that can be used, but I'll just say this. If you're worried about, if you're an active user and you want to not be, and you're worried about withdrawal, a poison center is there 24 hours a day. And they might ask you to go to healthcare to be evaluated. Maybe they won't. Maybe they can give you more information. You can also always go to healthcare. But I think any substance that you are interested in stopping using and you're worried about the health effects, doing that in conjunction with a medical professional is absolutely the right move. You should never feel scared about reaching out to someone about wanting to reduce substance use in your life and have help and support with that. There's no protocol can or would. There's not a one size fits all for everyone. There's many strategies that are used, but there's a lot of people out there with resources to do it. Poison centers are 1-800-222-1222. They might link you into care and then help that healthcare provider manage your withdrawal. But this is something that's done routinely. So we can get people off of this if they so choose. It's not something that is all that scary to do because it's familiar to other drugs that we help people get off of, like fentanyl or all these kinds of things.
People struggle because how did I get addicted to this over-the-counter thing that's not supposed to be addictive? And there is a lot of experience of going to health professionals and the provider having to Google what it is. That's less so by the day that those stories are being reduced because it is becoming so much more prevalent.
And in a specialty that deals with the weird stuff, I've written an entire paper on how to treat phenibut withdrawal, which is something that everyone calls. They're like, oh, what do I do with this? There's people out there that know, and any healthcare provider has access to poison centers 24/7. They can also help with those things. So you can even suggest to your provider, hey, can you call the poison center, see if they have any thoughts? This is something that we deal with.
Looking at the banned state advantage where there was like 3 times fewer severe outcomes and calls, was there anything that you could surmise other than just the access reduction in the banned states that might be leading to there being worse outcomes in banned states?
There's several explanations. So like we said, this is an association. We see this result for sure. Whether the cause is the ban, I don't know. There could be other things. Maybe in the banned state, people are less likely to report that they're using Kratom, and they're less likely to call a poison center, so we never get linked into the system. It could be a bias of the way that we're collecting the data. I can hypothesize some things. I personally think you're just less likely to run into Kratom, and that means you're less likely to see these things. When I was in Arizona recently, I bought some Kratom at a gas station because I said, this is interesting. I can't buy this in my state, but it's sitting right here at the front of the store as a 5-hour energy shot. How would somebody not buy that? It's very accessible, and a lot of people don't even know what it is. They might even think they're buying a 5-hour energy. It was literally in a small bottle like that. So I could see why it just gets into way more hands. And this is not any different than if you look at the rates of alcohol-related disease in, I think, but Saudi Arabia, where it's prohibited, they have a lot less alcohol-related disease. Just like how here in the U.S., where it's regulated very strictly, we have a ton of alcohol-related disease. So it just makes sense. What's happening to all those people who are we seeing higher rates of overdose deaths from other things is a question. If we introduced Kratom into our banned state in Wisconsin, would we see a reduction in overdose deaths? That would be a very hard thing to measure. I've seen no convincing data that it does reduce overdose deaths in any way. We tried to actually look at this in our own study. We did what's called a sensitivity analysis, where we looked at SUDOR's data, which is basically a CDC data set that reports out on overdose deaths reported to medical examiners. And this is how they measure the impact of other opioid-related interventions. For example, if you introduce naloxone training into a community, you can usually see a reduction in opioid-related mortality in that community using SUDOR's data. I know at least one study I could show you from Alexander Wally, 2013, that showed something like that. But so we looked at SUDOR's data for opioid overdose deaths based off of banned states versus other regulation, and we did not see a difference. But this is unpublished data. Nobody's reviewed this. I'm just letting you know something we looked into. We didn't include it in our analysis because it's a long manuscript and it's hard. It was also a limited data set. It was only 3 years because SUDOR's only collects for so many years. And less of the states actually participate in this SUDOR's data set. So we couldn't compare all the states together. But we tried to look at this. We couldn't find anything. Doesn't mean it's not true. But it doesn't mean that states with Kratom bans aren't experiencing more opioid overdose death. I'll say that. But I also haven't seen data that they are experiencing more overdose death that is convincing in any way. I've read one thesis that somebody sent me on Instagram that doesn't really prove. It looked at rates of opioid overdose death in 3 banned states around the time of the bans and said, oh, opioid overdose deaths did increase around between ban and non-ban time period, but that also would happen in any other state because it was in a time frame where opioid overdose deaths were increasing nationwide. You can't really look at the ban as the cause of that.
I fed that data into an AI platform and looked at the overdose states in some comparable states nearby those banned states where Kratom remained available, and their overdose rates had a similar pattern.
Right.
So none of this proves causation or anything, but I would just guess that there's just an overall increase of overdose nationwide, and all the states had a similar trend with each wave of opioid spikes that we had.
You'd really have to compare it like we did in our study, banned versus unbanned states in the same time period in order to make, and even then it's just an association. We still don't really know causation.
Is there a way of any of these things that we're looking at to prove causation? What would you have to do to be able to do that?
That's such a hard question. There's 100 ways to look at this data and the harms on both sides of regulation. And none of them are good. They're all imperfect metrics. So it's probably one of those scenarios where we're going to have to collate multiple studies and see if a trend of harm in one direction or the other is repeatedly shown using different metrics to really weigh our final option here. If you're asking the question, does opioid overdose death go up when Kratom is available? You probably need to do that more as like a cohort study. Get a group of opioid users or Kratom users and measure them over time with a survey that asks what substances they're using or follow their health outcomes over time. And try not to bias it with saying, hey, are you using other opioids now that you've stopped using Kratom? It would be very hard to do. And I don't know that there is a real answer. You could look at the impact of introducing a Kratom store into a community with opioid overdose rates and maybe look at the opioid overdose death rates in that community. I have concerns about people using Kratom as an opioid alternative in the first place, because I do think it's important for anyone with a substance use disorder to be the drug side of it is only part of the battle. I think it's important to at least have a relationship with a provider who can help someone through the cognitive side of substance use disorder. So people self-treating, I get it's better than using more illicit opioids, but are we also preventing people from reaching care that might be more long-term positive impact as opposed to just an opioid replacement therapy? That's one thought of it too.
Our experience of our listeners and our co-host here is it ended up being a transfer addiction for those of us who had an existing substance abuse disorder. And for new people that was their kind of first rodeo with a drug of abuse, it just resembled like an alcohol or other abuse. It is a functional drug. So people had a more of a honeymoon period with Kratom. There's often an instrumental use that most people use it to either to perform better at job or home or to self-treat symptoms. And there was benefits at the beginning, but because of the tolerance and withdrawal and dependence, needing to dose more frequently, it eventually was no longer a medicine for anybody or a performative boost for anybody that appeared on our podcast. And it was something that they eventually had to abstain from to get their life back on track. I know that's not universal because there's a lot of self-reports of it acting as a natural Suboxone for some people, but we're very wary of recommending that to anybody that has a history of substance abuse.
The natural Suboxone thing is, we don't have enough access to Suboxone. I'll say that much, or providers who can help people with substance use. But I also worry about if Suboxone was over the counter, I wouldn't want people just taking it by themselves. Different thing, but it's important, I think, in these, I'm trying to think about it. It's important. Part of the medical care of substance use, which is my bias, that's what I am involved in, is having an objective relationship, which is hard to do if it's just you self-treating, right? So it's important to have a counterpart who can help understand, okay, how is the use going? What doses are we on? These kinds of things. In addiction medicine, I think that's a really important piece to it. And in substance use overall, it's an important piece, is having a community to be part of. For the name of this podcast, I think is Kratom Sobriety, right? So community is a really big part of sobriety as far as I'm aware, right? I worry for people who are using Kratom to replace other opioids, are we missing an opportunity for them to be linked in with care or other programs that are very successful? And they might say no, and that's fair. But it's just another thought I have about the free availability of it. And then, okay, now you're using Kratom to replace your opioid. Who's regulating the Kratom? Is it suddenly going to be full of pseudoindoxil at 10 times the concentration? That's actually what I see on the other side of this, as I deal with a lot of the harms of unregulated substances. So at minimum, I am actually very pro-regulation of Kratom, at least. What we do with it from there, I don't know. Ban versus unregulated, I don't know. I just would like to avoid those harms of somebody accidentally getting a 10-fold overdose or Kratom contaminated with salmonella, those kinds of things that we can actually handle in the pharmaceutical and medical industry because we have strict regulation around it.
A couple more questions. Through the poison control data, did you learn anything about drug interactions and dangerous things like that?
There are drug interactions with Kratom. It interferes with the metabolic system, 2 of them that are really important for most drugs, actually. One is called CYP3A4, and the other one is called CYP2D6. And CYP2D6 is what metabolizes opioids. I don't have very clear, concrete examples, but I would just say it's feasible that it can boost the effects of other drugs they're taking that could potentially make them more harmful via stopping them from breaking down. There's not one drug interaction, I would say for sure. Avoid this with this, but it does seem like it could interact with things, which just introduces more complexity to assessing what is causing the harms here. Someone taking Kratom and then they're on an opioid normally, and then suddenly they take Kratom and it now reduces the clearance of that normal opioid they're taking. Are they more likely to run into an opioid overdose? These are all things that we'd potentially run into.
A lot of the Kratom deaths involve co-ingestion of common over-the-counter meds like Benadryl, antihistamines, and then common prescriptions, often antidepressants. So in general, we recommend not mixing Kratom with another medication. But yeah, definitely talk to a doctor and just be careful about that. You noted in the paper that prior Kratom research is often funded by industry-affiliated groups. Did you want to discuss that in any way?
In fact, it was brought up by some of the reviewers of this paper, but there is a lot. What has been recently published is often, and you could find it, not everything, but there's plenty of stuff that is affiliated with, I think it's the American Kratom Association or businesses that are consultors for the American Kratom Association. So this is the big important part of research, is disclosing your bias. And it's okay to have a bias. Maybe but you got to understand that bias is probably going to impact results that are reported. I'll disclose my bias, which is that I see people get harmed from Kratom, and that's the number one way that I interact with it. Now, I see that specific harm of overdose or withdrawal. I also see people harmed from opioid overdose. When I think about Kratom overall, the data for Kratom is either very limited because our metrics are poor to measure all these outcomes, or often I find it affiliated with industry bias that has a clear agenda to ensure it is accessible to everyone. And they're also using poor metrics, right? So there's no good metric out there. So it seems to me the viewpoint of any given person for Kratom is primarily based on the lens in which they interact with it. And some people probably interact with it in a way that positively benefits them, or they've seen someone else be positively benefited by it. And others interact with it primarily dealing with the bias of the harms associated with it, such as myself. So I get it. That's why I think if we want to remove all of our own biases, the one bias I would be concerned about is the bias that would ensure continued access regardless of harm or benefit which would be that of a monetary industry bias. So that's the one that you should really take for a minute and say, what purpose would they have to put any of this data out? And we realize that, and that's big in pharma. It's not a Kratom issue. I read drug studies all the time for my job. I say, okay, this drug company wants this drug to come out. Of course, they're going to make the study look good. There was a recent example of that where there was a blood thinning drug or a reversal drug for people on blood thinners. And it got published and everybody said, this is why it's important to have somebody familiar with data assessment helping make these decisions, because this drug came to market and everyone said, I don't think it actually works that well based off this data. And it was never used. And finally, the drug is called Indexanet Alpha. And it was actually removed from FDA approval just a couple of years ago because all the healthcare workers said, okay, you published the study, but it's biased. And also it doesn't show that great of results. So I don't know, just kind of something to think about. We were excited to be able to put out some non-biased data.
I appreciate it. Obviously, I have a bias about the harms, and that's because mostly that's who I interact. And I do feel like it's unbiased to say that it's underappreciated, the risks associated with Kratom. It is a $2 billion plus industry. And I do think the industry itself has a bigger platform to market and promote their products in the most favorable light and minimize the harms and maintain access to the marketplace. And I do feel like that causes harms. So let's take seizures. There was recently 2 papers published about Kratom seizures. And one was from, I think it was a foreign researchers that had no affiliation with the industry. And then this other group, their business was helping companies basically evade FDA oversight. And they looked at essentially the same Kratom related data related to seizures. And the one that was industry affiliated said that there was no proof that Kratom caused seizures or was even associated with seizures. And the other one said that there was a lot of signals showing that Kratom probably is causing people to have seizures. And I've just met so many people that have had seizures associated with Kratom, and the seizures stopped when they stopped taking Kratom. To me, it's mind-boggling to say that Kratom isn't causing seizures.
I've not read these studies or assessed them, but it is very clear that data can be interpreted in the context of bias. And this has been shown many times in science and medicine. And you can look at the same statistics sometimes and come to different results depending on if you have an agenda that you're trying to put forward. So it's important to try to put things forward without an agenda, which is what our study did. We just wanted to see what the results were.
Yeah, I'll forward both of those studies to you. In the poison control data, there's some linkages between Kratom and seizures, right?
Yep. One of the deaths was related to somebody who appeared to have seized. You can have seizures sometimes if you're having arrhythmia and your heart stops, and then you have this kind of seizure-like activity. So who knows? And I haven't sussed out I have not done an analysis on how often Kratom and seizures have been associated with each other, but it was at least one signal that we saw. There's other opioids that can cause seizures. I'm not saying that it does or does not. It was a signal that we saw. It wouldn't surprise me. There's what we call biologic plausibility in theory. We're learning more and more about the potential overdose or toxicity related effects all the time. So if I found out something can cause seizures, wouldn't blow my mind.
So if you were asked to testify in Wisconsin about your paper, what would you tell legislators there about regulation?
I would simply say we need to look at this from multiple angles and consider the impacts on both sides. There are people who use this to manage pain. There are people who use this to manage opioid use disorder. I think we should probably focus on expanding access to opioid use disorder treatments within the medical profession as opposed to using unregulated substances personally. I think regulation is wildly important for products like these to ensure that, okay, if people are using them, that they can at least maintain accessibility of the same substance with the same amount of drug in it so they don't risk experiencing overdose or withdrawal. I think we really need to look at what kind of harm can come from chronic use. That's not something that's really been evaluated. And I would want regulation at minimum. I don't have enough data to really say much about the harms that, if you think about it overall, when you have harm on both sides, you have harm of it being available and you have harm of it not being available, right? It becomes a question of utility, which is really what is the greatest good that comes from one of these decisions? Kratom is not the biggest problem in the world right now. There's many others, I'll tell you that. But it's something a lot of people are talking about due to regulation. And I don't know if we have enough data to inform the utility decision on the harms of banning. We now have some data on the benefits of, or I guess we'll say a benefit, on how often we get called to a poison center about people dying or having serious effects if it's banned. But I don't know if we've looked hard enough at the other side. And it would be good to see some more unbiased data on that side too, before we make a decision. Although right now, Wisconsin's decision is it's banned. I don't know if it impacts anyone else's life because they're not using it right now. Or they are, and they're ordering it on the internet, and that's fun.
Well, I'm going to put you on the spot. Let's pretend I'm a Wisconsin senator, and I'll say, Doctor, do you think we should overturn the ban in Wisconsin on Kratom based on what you know?
I would say I'm not a regulator, not my area. I'll give you the data, and you can think about the systems it affects. And maybe once I have enough data to weigh in, I could. But right now, I don't. I'll keep looking and trying to find out. I don't like to. Government makes decisions to deal with problems. Science is looking to find the truth, and I'm a scientist. That's mainly what I'm doing. So I'd like to know the truth, and then they can use that to inform their decisions. I will say my life is simpler with less substances in it, and the less substances that are accessible. We're basically saying, what kind of system do we want to make available for people to insert themselves into? Do we want a system where people can accidentally develop dependence to kratom, or a system where people have the ability to self-manage their opioid-related use disorder with something like this? But is that the safest way? I don't know. So it's just a question to ask. More research should come out.
Thanks a lot for detangling these issues. It is a serious topic, but to all the quitters out there, it is possible to get off kratom. We demonstrate that with our stories, and you don't have to do it alone. And calling poison control is an extra resource that we never recommended before in the past.
I appreciate the show, Charlie. This is a great thing for people who maybe have developed dependence, and being good examples of that you don't have to live with the substance in your life if you choose not to. Obviously, there's difficulties with all that. So I think it's a great thing that you're doing. And I appreciate actually you sharing some of your perspective. I want to be sensitive to the topic that I'm fortunate to not have dependence on kratom. And I want to help people who do or are experiencing effects from it, but really learning from the lived experiences of those who were dependent on it and are no longer, got through it, or we learn a lot from our patients. And I appreciate getting to learn what your side of it is too, and how you see these perspectives about the regulation. Wait, can I ask you a question?
Yes.
What do you want? Do you want it banned? Do you want it freely available? Honestly, you're probably a better person to weigh in than me.
I have some really mixed feelings about it. Politically, I lean toward a libertarian, and I do have concerns about harm reduction and things like that. But I interact with the families who had a kratom death, and they're very adamant that they believe that kratom should be banned. And many of them believe if kratom was banned in 2016 when the FDA proposed it, but that was pushed back. And so they feel like their family members have been guinea pigs for this product that was on the market without being tested to make sure it was safe, and that their loved one would still be alive if it had been banned across all 50 states. And so that interacting with them and their pain, and partly is because their experiences are erased and denied because the industry and the kratom fans say that it's impossible to die from kratom.
Yeah.
So that's makes their loss even more excruciating. But it isn't a black and white question.
Yeah.
I have a friend who does kratom a couple times a month, 1 gram, and it improves the quality of her life, and she doesn't have an addictive relationship with it. And unfortunately, she's not a kratom partisan and isn't engaging in kratom death denialism and stuff like that. But shouldn't she have the right to continue accessing kratom because it's pretty safe for her?
Yeah.
My beef is actually more with the industry. I think it's predatory, and I think they could have proposed more strict regulations at this point. Beyond the Kratom Consumer Protection Act is really light regulation. Kratom is still just being treated as a supplement. We could get a big debate about the supplement rules in the DSHEA Act because there's all sorts of supplements in the market that are kind of shady. There is not a simple solution. Even when there are strict regulations, a lot of times there isn't the resources for that state to enforce them. And that's the argument with the people that believe in Kratom bans. There's no way to regulate it. You just got to wipe the whole thing off the market. And many of them will say, then you need to do that and then explore maybe making it by prescription or maybe selling it out of a dispensary model like legal weed. It is really complicated, but I do support the community that believes that Kratom does cause harm.
I just want to find out what would do the most good. And I see both sides here. But there's one thing I'm adamant on. There needs to be regulation, at least asserted, especially around the advertisement and labeling of it. You bring up a good question about freedoms and who should you not be allowed to do this or that? Sure. But do you also need to have Kratom marketed to you in a gas station? If you know about it and want to use it, can you use it? Or do you need to, there's things that we don't set, there's marketing restrictions on certain things, right? I wish there was more marketing restrictions on a lot of things, like direct-to-consumer advertisements for pharmaceuticals. I don't think those need to exist, but for a lot of things. But yeah, does everyone need to know? Because I actually think that happens to be why we see such a big decrease in exposures in banned states, is you can't advertise it. Because when you look at KCPA states and unregulated states, both of those can throw a big thing in the window that says, free herbal extract here that will help with mood. They could say whatever they want. But if we really did more transparent, you can have the freedom as long as everyone has the right information to make the risk assessment. I think that's the important part. Otherwise, you're actually naturally engaging in a predatory relationship where someone is not disclosing the full potential harms with the bias of trying to extract money from you. And that's, by definition, it's predatory. So I would love to see that more just overall. So regulation, even at least around advertising and labeling would be really great. I'll stand on that firmly.
A lot of vendors, they do free samples and loyalty plans that encourage repurchases and buying more. The one thing that makes me pause and lean towards a ban is I think the deadly interactions is way bigger than we understand. And I've just talked to so many people that were their adult child, so a 25-year-old, he's a young man, but he took one Benadryl and then he took some Kratom and the next day he died either in his sleep or sometimes people have seizures or they throw up and die, the aspiration. How to prevent the interactions, I don't know.
Yeah, I'll say I'm always careful without objective. I'm too much of a scientist sometimes. Anecdote is incredibly powerful, but I need to see the data and signal replicated and have all the right, because there's so much that and there are interactions, 100%. We don't know them all. And like I said, deaths are probably underreported. I want to see more study on that for sure, because that will really help us inform things, especially if we can replicate data showing harms associated with a specific drug interactions that will help us all be more informed on what to avoid. But yeah, absolutely.
And the science, it is signal data, it's case reports. There just isn't random controlled trials with causation.
Not yet. Maybe we'll inspire some people.
The families are worried by the time too many people have died and the market will be so entrenched that there will be no turning back.
That's totally reasonable.
I really appreciate you having this. I know some of the families I work with will probably be frustrated with me that I didn't have a more stringent, clear discussion with you that Kratom absolutely should be banned and there's no questions. Personally, I don't think it's black and white like that.
I agree, but I would love to not see anyone else unintentionally harmed by a substance that they weren't aware of and did not. Whether a ban is that question, I'm not a regulator, but our data certainly does show some interesting signals.
So thank you so much and take care.
Thanks, Charlie.
All right.